It's a great pleasure to be with you today in Hawaii or wherever you are. This is the closest I'll get for a long time, I would imagine, to being there. And it's good to be able to share our experience in thinking about large language models and generative AI. And over the last couple years, we spent time thinking about how to do this well and how to get this used by our community. And we'll talk a little bit about that and some of the challenges. And there'll be plenty of time for questions at the end. So save them or interrupt us as you want. Either one is fine. I'll say a little bit about Dana-Farber Cancer Institute before I start. It's a National Comprehensive Cancer Center in Boston. We are a Harvard Medical School teaching hospital. We have about 50% research and 50% clinical care. It's sort of one of very few places that has this kind of balance. So a lot of what we're trying to do is bring the best research into practice and the best data from clinical practice to our researchers. And my team is informatics and analytics. Our department sits in between, and we help enable research, but we also help enable clinical and operational work as well. And I will jump in. Let's see. And some disclosures. I guess the most relevant of these is I have a few $1,000s of stock in Microsoft, and I'm going to talk about Microsoft.
I just wanted to say that Dana-Farber and UH Cancer Center are the two farthest apart cancer centers in the nation. We couldn't be farther apart. Only in distance, I hope. We hope to converge to.
Yes, there is a direct flight to Honolulu. I think it's like 12 hours long.
That's right.
I have not taken it yet, but someday I would like to. Okay, so we'll talk through some of the background and history of the project. This is really a deployment project and how we thought about the decisions we were making, a few of the decisions that we used to accelerate the process. And I'll talk about 3 aspects of the project that I think were particularly important along the way. And then Renato will take over and talk about how our users are using the tool that we've put in place and where we're headed in the future, and that there will be plenty of time for questions. So starting back a couple of years ago, a little less than a couple of years ago, when ChatGPT was released, I think it opened lots of people's eyes to the potential that AI would have, that large language models in particular would have in every industry. But certainly true for cancer research and clinical care and patient experience and operations. And I don't think it is a hype. I mean, there is a lot of hype, but I think it's largely going to bear out that this is going to be transformative technology for all these areas of for healthcare in particular, as an industry that has so much inefficiency in it and so much opportunity, I think, for AI to help remove work that isn't directly providing value to patients. So there's a huge opportunity here. You are aware of that. That's partly why you're here and have this series, is that there's enormous potential here. Oncology, as you probably also already know, is particularly dependent on things like text and images that are suitable for generative AI. And we take, well, a lot of our information that matters the most, diagnoses, treatments, outcomes, to how we treat disease and how, I'm not a clinician, so I'm not treating disease, how we as an institution treat disease and how we store the information, and then how we abstract it back out for research really is about text. And we look in images to understand if a cancer has progressed, and the results of that, whether a cancer has progressed or not, or stayed the same, or regressed, or is cured, is sort of stuck in text in the medical record, or in the imaging report, or in the pathology report. And then we pull it out again to use for research purposes, for regulatory reporting or reimbursement. So we put it in the text and then we take it back out again. And this is going to change. And large language models are particularly useful for text and images. I think these combined tools will be particularly interesting to use. So there's a lot of potential in oncology specifically for these kinds of tools to help. They're also a great risk that's different than other kinds of AI. Generative AI doesn't have the nice, clean properties that you can understand where it comes from, and that it gives you consistent answers, and that it it has the benefit of creativity, but creativity isn't always what you want. There's also, in the public tools, it's unclear where the models come from and whether they're consuming copyrighted information or other things in order to build them, and what text you get out may have come from anywhere. So it's a little bit hard to use for clinical care, for example. And we are concerned about our clinicians using ChatGPT or other public tools and unknowingly violating HIPAA, and we don't really want them to break the law. We also don't want people putting in their research discoveries, rewriting their reports in some way and accidentally disclosing that information, and putting information into a public tool may equate to disclosure of intellectual property. So you may be, publishing your information when you don't intend to by using these tools. And we also are a highly regulated space, and grants are regulated, journals have rules, and we don't want our research community to violate those rules, especially without understanding that they're doing that. So we saw significant risk and significant benefit from generative AI in the beginning of the year of 2023. And that sort of began our journey, was recognizing that this was the potentially transformative and also kind of a problem. So we looked at different options that we could do. We could ban large language models, which was our first thought. Maybe we should just put out a ban that we shouldn't do this. But as an academic medical center, and innovation is our brand, really, how would we do that? And we felt like people would probably ignore it anyway. And off the record, I guess this is recorded, but it's hard to tell researchers what they can't do. It's better to give them something that they can do and steer them towards that than it is to try to tell them what they can't do. We thought about building a private large language model, either ourselves or with a partner, but that seemed to be very expensive and likely to be slow, and we'd be behind the curve. We also explored using open source options, and many of those are quite promising. We were worried about having to do too much fine tuning and having to do that fine tuning iteratively over time. It might take us a whole team, to set up these models, and the cost of maintaining that would be relatively large. And we also might not get the same versatility and value and up-to-dateness as if we could just somehow use the tools that were being put out in the public domain. And so what we wanted to do, and the question that we asked, was, can we deploy a commercial large language model inside our firewall in a private and secure way that would be HIPAA compliant and that we could make available to our entire workforce, and hopefully affordable as well? for broad use of our workforce. We have about 6,000 employees at Dana-Farber, and that they could use it for PHI, PII, and intellectual property, or those kinds of use cases that were more sensitive. Would that be possible? And so we asked this question, and Renato took the question and ran with it, really. And the result is what we will show you today. But the idea was quite simple, which is, can we take GPT-4 and make it available inside with some warnings and welcomes, and this is our policy on the front, but it's basically as simple and easy to use and as fast and as GPT-4 itself, if ideally. And originally we called it GPT-4 for PHI because that was the concept, or the most sensitive aspect of the study was, can we do this in a way that would be HIPAA compliant? That was the main question. So we first looked at feasibility. We had a business associates agreement with Microsoft that covers our cloud infrastructure and online services, including the Azure environment that we used, and the tools that were within that environment were HIPAA compliant, or at least some of them were HIPAA compliant and approved, and we could sort of indicate which ones were and which one weren't. And we worked with Microsoft, and they happened to have this new partnership with OpenAI to make sure that GPT-3, 3.5, 3.5 Turbo, and 4 were inside and available in that Azure environment as services that would be HIPAA approved. And with that in place, that partnership with Microsoft, in a sense, we were able to imagine at least that this would be theoretically secure, HIPAA compliant, and covered in our BAA agreement with Microsoft, the same way that we use other tools from Microsoft like Outlook and OneDrive without worrying about the privacy of those. And this would run inside our Azure data centers that would be isolated from OpenAI, which we wanted to have be the case. We didn't want our text and content to be shared with OpenAI or built into any new models or accidentally shared with other companies or institutions. So that was the idea. And we also looked at what engineering and expertise would be required to set up the platform, and luckily Renato's team had that expertise and could configure the toolkit that was provided could be set up to meet the requirements that we imagined that we had. We didn't know exactly what we need to do, but we had the expertise to do it. And then we made some estimates about how much time it would take and how many people it would cost, and then what would it cost to run it, and that they seemed pretty reasonable. And those estimates have held true over time. I'm happy to report that they weren't, if anything, we're running a little cheaper than we thought it would cost. So that's good. So I'll talk about 3 decisions that we made that helped accelerate the process. Maybe I'll start with the middle one, which is the choice of a commercial partner, because I already mentioned this one. Working with Microsoft helped us to accelerate because of this mature environment. We basically already had a fairly mature data environment with computational tools and security there. And as part of our partnership with Mass General Brigham, we share some IT infrastructure, and they deserve credit too for this environment. And Microsoft partnership with OpenAI was particularly convenient in this regard. We could have been with other partners, but it happened to be convenient that they had this partnership. We had the environment. We do have environments set up for Google and other partners as well, but this was particularly helpful in this regard. And we were able to configure a ChatGPT-like tool using the ChatGPT LLMs underneath, but meeting our own requirements and specifications and configuring it ourselves. and Microsoft was very helpful in making their technical teams available for debugging and review, and they understood in a way that we've rarely seen, I guess, the constraints of healthcare compliance and that they got what we're trying to do and why, and they understood HIPAA, things like that. They were pretty flexible and responsive and supportive as they could be with quota requests too. They had many companies and many institutions that wanted to be using these tools, and it was great that we got a little bit. And over time, as we went through the project, we were able to add more and more computational power to the project. We couldn't have started deploying it to 6,000 people on day one. They didn't have the capability, and neither did we. So it was helpful to build the relationship with them over time. So this was an accelerating choice of partner. And we didn't give away anything to them either. We pay them for the services, and they don't get access to our data or anything else. So it was a good partnership. But the number one decision I would say that we made is to start with governance. And this I have this slide, which I probably should have put in, which has governance at the bottom of the pyramid. It's really the basis that you build everything on when you're doing an IT project or an informatics project or any piece of work. What is the governance of it? How do you set this up? And I was a sponsor of this idea, and we also had support from our CIO and our general counsel that we wanted to explore this, and that there was significant need to do this. There were a lot of people that wanted to use these public tools. We were worried about the risks, so there was quite a bit of interest from the community in having something. And so we knew we wanted to do something. We, as sponsors of this, recommended that we create an AI governance committee, which was called a generative AI governance committee at the time. And that's still the major emphasis because of the difference between generative AI and other AI. We don't feel the need to have a special committee to regulate yet AI tools that have very clear inputs and very clear outputs and operate in the same way. Or they still need regulation, but it's very similar to other kinds of tools, and we have experience and other governance processes to deal with them. Whereas generative AI brought in some new challenges and twists into this, as you're full aware. So we were focused on this, and we wanted there to be a broad representation of departments and functions, from clinical to operational to business areas to patients and providers, so that we could have lots of input into the problem and the opportunities, and to help us think through the risks and benefits and compliance and ethics. This was about a year and a half ago that we created this committee to look into this. And the first function of the committee was education for ourselves, largely about the legal, technical, and privacy issues, all the different kinds of risks, and how they were being dealt with by other institutions. We did a lot of literature reviews and searches. We had presentations on different kinds of risk and what they meant and how relevant they might be to our environment. And that was the first few weeks anyway. It was largely about that. And the committee decided to kick off 2 work streams in parallel, partly because of the urgency of this project. We knew that we really wanted to get something into the hands of people, because they were going to start using, or we're already starting to tinker with public tools, and we wanted to head that off by giving something else. So we gave Renato the job of coming up with a secure technical implementation that would have content filters to protect our users from copyright or from violent language or other things that we didn't really want to get into and didn't want to have happen, and with full logging capabilities and auditing capabilities. And those are things that were part of this configuration model. And at the same time, we started working on the policy for usage. What would we allow? What would we not allow? How would we communicate with our community? And I think pretty early on, we sent out a communication about reminding people not to paste in parts of medical record into a public LLM, that would be bad. And that was some of our early amazing communications were focused on that. But how would we communicate? And the hope was that we'd have a technical implementation and a policy ready more or less at the same time, so that in this way we could save some time. And there was lots of discussion. Lots and lots of discussion. And the third decision that we made was the one that really helped us move out of the discussion phase and into the deployment phase. And that was the third thing, which was prohibiting clinical use. So we decided that we didn't want direct clinical care to be part of what the tool was used for, or direct patient use of the tools outside of controlled studies. And by controlled studies, we either mean an IRB approved clinical trial, which is a perfectly appropriate way to start to understand the risks and benefits of a new technology. And we wanted to encourage that. But we didn't want sort of random clinical use in a variety of different ways. And we also wanted to support dedicated pilots that would be done with the IT infrastructure, so that something like ambient AI for clinical notes, drafting clinical notes or something, that was also conceived of as supported by what we would try to do, but we do it in a very controlled institute way with the IT process. So when we set aside the clinical use, we set aside a lot of high value use cases, and it was a bit of a sad moment, because we were setting aside things that we knew would help patients, we knew would help clinicians, and but we felt like we would get there eventually, and we didn't feel like our decision-making frameworks were mature enough to be able to navigate these use cases, provide guidelines to our clinicians and patients how to use the tools. We didn't feel like our regulatory infrastructure was mature enough to guide use of these things. And there wasn't really much evidence that the general trained large language models trained on the internet as a whole would really adapt that well to broad sets of clinical oncology use cases. Some things would work pretty well and some things wouldn't, and a lot of it would depend on how good your prompt was or how you iterated, and it was really hard to predict what would work and what wouldn't. And some things worked great and some things didn't, and how would you know if something was going to work or not? If you were translating something into a language you didn't understand, how would you know if it was correct or not? And what are the risks of that? So we set aside these use cases that we knew would have a lot of value, but we were thinking that we just didn't have the decision-making frameworks immature enough in the regulatory process. We had a lot of work to do. There was going to be a lot of work for each of these use cases to really ensure a productive integration into the clinical workflow, how we would protect patient dignity, how they would consent, what would the consent say, would they have to consent, how would the autonomy of patients work, how would we limit and prevent bias, how would we mitigate it, how would we prevent drift, how would we give guidance to our clinicians for each of the use cases. There's just a ton of work to do for any particular use case, let alone a kind of open-ended thing. So this was a fairly big decision, but it allowed us to accelerate quite rapidly towards the other kinds of use cases that our community would benefit from, operational, research, and administrative use cases. And it wasn't that long after that decision that we were able to release a version of the tool, because we had done those in parallel, working on the technical with a guess at what the policy would be, or at least an idea that we'd have a policy ready. and we were able to put it out and have it be used. This is about a year ago, to have a generally available tool. We didn't market it broadly because we didn't really have the compute quota to support the whole community yet. And we wanted to get feedback and do this iteratively by releasing it to different departments and understanding the value proposition and what kinds of support they needed, what kinds of training they might need, what kinds of policy clarifications might be needed. But that's what the first release looked like. So the first 6 months of the project began with conversations and this sort of idea phase, and then the feasibility phase in month 2 in our first meeting of the committee was in the second month, where we imagined what it might look like and sort of talk about the pros and cons of this. This is where we also had the feasibility assessment in month 2 and started thinking about technical requirements and security and quotas, and began meeting with Microsoft to explore that. In month 3, we had a working prototype, and we started thinking more deeply about how we would communicate the policy. And that's where we got sort of stuck, thinking about, well, what could you do, what you can't do, how are we going to manage this? And that led to this clinical care being ruled out. If we wanted to get this deployed quickly, we were going to have to set aside clinical care. And that led us to the initial release and some support for the community that went with it. We had a very small team working on this, so we, of a few people working on it. So there wasn't ability to get out and talk to every user about it and educate them. So we had to have materials that would help us do that. And over time, we released it to more and more groups and continued to work on the policy towards a formal final policy. We called this alpha or beta testing or something. We had different people using it and testing it. And anybody that was super antsy to be using it was using it at this point. In month 5, we had an institute-wide communication and guidance sent out about using large language models and what we and some guidance on it. And then in month 6, we were able to add more users. We were always sort of balanced between what the compute infrastructure could support and how, and sort of releasing it. So we sort of gradually worked to add more users and have them have a good experience when they were in the tool, and kept iterating and learning and adding improvements. And then we had terms of use language approved by the governance committee by the end of month 6. It was a sort of a 6-month project to get there. We had a lot more work to do at that point, though. And after that, we continued to have monthly meetings of the governance committee, and we did not have a final policy. We had sort of guidance documents, but not a final policy. And we continued working on that over time, adding training. We had weekly technical sprints still, trying to work out some of the bugs and kinks. We did a survey that Renato will show you of our early users, what that was their experience, what were they worried about, and we'll show you that soon. And we gradually released some more users while monitoring the performance. But anybody that asked for it, we gave them access. This point in week 13 here, we had an institute-wide communication with a link to the tool. Before that, we had released it department by department, and we'd said don't use the public LLMs, but we hadn't really sent out the link to the new tool. And here we did, and we then had thousands of queries per week, where we had hundreds before. Excuse me. And we started then monitoring the load and the usage, and eventually got to the final policy approved. I'll talk through a few other aspects of the project that we found important, that I consider important in the project. The first one is an ethical framework, or thinking about how you do this in a process framework. A few of our colleagues had published this paper a year before. This is how you would ethically deploy AI in oncology. in JCO in 2022. So this is about a year before, and it was focused largely on the clinical aspects of AI, but the framework was also pretty useful to us. So we took the major aspects of that and tried to be guided by this. We also included some of the authors were part of our steering committee as well. And they included making sure that the decision-making process, the reasons, the materials used to make decisions were relevant and important, that we kept a transparent process along the way, that we would iterate in a transparent way and revise based on feedback that we got, that we would include the people in the process that were affected by the process, including patients and clinicians, and that we would have clear policies and ways of auditing and checking that those were being followed. And that part of our configuration was to make sure that we had these in place as a way to check the environment. The second aspect was how we did training. We embedded support materials inside the tool so people could learn what generative AI was in the tool. Many people of our users didn't really understand how it worked, or what it was, or what it could do, what it couldn't do, what were the risks, what would the words mean. We could also give them prompt engineering strategies and technical training and best practices through these tools that were embedded, because we knew we wouldn't be able to get of users this way. And because we're an academic center and learning and exploring was really a big part of this project, we wanted to get the tool in the hands of people to learn and to try use cases that we weren't going to think of, and to test things out and share with each other what was working and what wasn't working. And so this Teams channel is another example of this kind of socialization by crowdsourced socialization. Not today I used AI for something, and what was it and how does it work? We could share other things through these channels. And we also went department by department, starting with the more technical groups and moving towards more clinical and business groups, to make sure that we had presentations that were tailored to their types of use cases and interests, and we're learning through the process how to make a good presentation and how to anticipate what their questions would be, and building better and better training materials over time. This iterative listening process, I think, was key to the success of the project. And there was a ton of enthusiasm from the community to be using something, and we tried to harness that enthusiasm to help create materials that would be needed, to have input from people about what they needed and what they were worried about. We listened to power users and tried to listen to all of the different clients that we had. We had a ticketing system and an intake form, which helped us with the sort of IT aspects of the platform, which have been quite smooth. But this iterative approach really allowed us to accelerate, and that was true really after we excluded clinical use, that we could accelerate. And we've continued monthly meetings with Microsoft to make sure that partnership is working. So at this point, I will hand off to Renato to talk about how our community is using the tool.
Thank you very much, Jason. So we have really an opportunity here to show you the uses of this tool, because we have had it for over a year yesterday, now in production. This is how people are using it. These are the early adopters. So the very first survey, few dozens users, they said that their most useful contribution for around the GPT-4 was for extracting, searching information in notes, in reports, in other documents, and files in general, as well as answer general knowledge questions. Fast forward to now, so 1 year later, what we see is, very interestingly, we have a lot of other use cases also appearing. Drafting, editing emails, minutes, presentations, that remains king, together with answering general knowledge questions. So basically a solid alternative to Googling information. But what you see is that also the other use cases were now starting to pick up. In other words, our users are becoming more savvy. They are really understanding better this tool, and they are able to create prompts that are more complex and that reflect a deeper understanding of the technology, as well as the integration that they can do with that technology. When it comes to concerns, this is what were reported initially. The first one was ethics and compliance with our policies, as well as inaccurate false outputs. So what basically generally is referred to as hallucinations in LLM lingo. What's interesting is that after we have had our policy and 1 year of usage, now we see that inaccurate or false output is the only one that now really remains strong. So hallucination is really a worry that people have. They're also interested now in additional things. So they want more training, as an example, and there are still limitations around the usage, such as they want uploads directly from certain sources. They don't want to copy paste the content. So these are all features that we are considering. And it's important now that ethics and compliance with policy, it's something that, because of the acceptable usage policy in place, is not spiking all the way to the top, is actually on par with other requests. So this is actually very, very good to see. It means the policy is working, it's enforcing, and it's disambiguating a lot of queries that people had in their mind. Next slide, please. And so we also use the GPT for DFCI to analyze its own logs, right? Why not? So we use the GPT-4 Mini, very inexpensive, still very efficient model to analyze all the prompts that were fed into the application. We analyzed, what you're seeing here is the past 6 months. About half of the use, even a bit more than that, is around help with technical coding, as well as summarizing, paraphrasing, editing, and critiquing text. So that's a very good insight that we had from analyzing the logs. Second, so about a quarter is related to operational, clinical research type of queries. Then also having this tool as a on-demand thinking partner, it's something new that we started to see. So basically, as you Google things, what happens is that you start opening some links, and then you come back, you revise your query, and on-demand quick thinking partner guides you through this process. You describe what is the status of your current brainstorming and guides you through a revised thinking. And that was very nice to see. So as of today, we have 1,800 users, and we run about 500 chats per day. And that's really nice. So what are we looking at in the future? Number one, we are opening up the API, so the backend that supports the web app you have seen in screenshots. We are opening that up to researchers so that they, being our primary consumer, this is what we expect, they can run complex prompts, and not just run them one or two, but run hundreds of them, run them against the different A/B scenarios, and really run with this innovation and have it inform their research. The pilot phase is complete, and we are opening it up to more and more users this month. The second thing, and this is regarding that hallucination point I made earlier, is a capability, and I have to thank my colleague Brent Mahan for suggesting we go this route, having a capability of querying through an LLM the repository of the documents that we do have across the Institute. So that could be a OneDrive folder, a SharePoint location, and so on and so forth, my past emails. You know, there are many, many connectors we could actually index in a vector database and use the LLM in a RAG fashion. And we're really building that as a capability. We have done numerous pilots. One was published in Research. We ingested the past 2.5 years of papers that were published in the context of computational pathology. And we were then querying this database of knowledge that, frankly, I don't think anyone will ever have time to read. It was over 14,000 pages of highly specialized text. And now we had it all available for querying at our fingertips. What is the best method to figure out that biomarker in that context? Would read a bunch of papers for us, compile an answer, and show in a RAG fashion what documents, meaning what papers it had read to compile that answer. And so that was very, very nice to see, and we'll be doing more of that. Next up will be really streamlining existing procedure and going after those use cases that are high ROI and lower risk, lower compared to clinical AI. As Jason said, we took off the chart clinical use, direct clinical use of generative AI, because yes, it is high ROI, but it is also very high risk, right? So we're going after those other use cases that are somewhat boring, but very high ROI. Think about revenue cycle, right? How many reimbursements you could support if you had an LLM to support your filings with an insurance and all of that, just to give you an example. And then the last one that is still in scoping is talk to my data live. That means being able to ask questions like, hey, what is the KPI status for my department financials around the project ABC, and take also into account the seasonality of that, right? Only an expert would know what all the acronyms I just used mean, and how to design the SQL queries, what documents to look at. And so we are building in the future a piece of LLM that will have access to our metadata, our data, our acronyms. It's writing the SQL, it's consulting the documents, and it's also creating charts. And again, this is in scoping phase. So to wrap up, what are the key summaries that you can take from this talk? So as Jason said, it was a sad but really accelerating decision to head off clinical immediate use. What do we mean by that? We use the definition that the FDA and the IMDRF use for that. So that basically means 4 things: to treat, to diagnose, to drive the clinical management, or inform it. Those 4 use cases were banned. They were banned to protect our patients, to protect our practice, to protect our providers, to really keep everybody in the safe. It's the same thing for drugs, right? When a new company invents a new molecule, you don't just go give it to everyone. You do a clinical trial. So we thought this is a terrific piece of innovation. We have to use a solid framework. Clinical trial is the way to assess this. You have a use case for treatment, go for it. Wrap it around the clinical trial and explore it through research, clinical research, right? So basically, this decision allowed us to enforce some of the best practices that we already had, shake off some of the early excitement, and at the same time, be very pragmatic, very deliberate about now the use cases that we were chasing. And again, it opened up hundreds of new use cases around basic research, clinical research, and operations and efficiency around that. Another thing I wanted to highlight is the companion AI models that come with it. When you interact with the UI through the web interface, there are a few dozen other models that run in the background against every text that you put in and every text that is trying to come out of the models. If any of that text contains any mention of violent language, sexual content, harmful content in any way, that is killed and is not either shown to the user or is not sent to the AI. It's still logged, but basically it's stopped in its track. Same thing for jailbreaking attempts. As you know, there are certain prompts that you can use to reverse engineer some of the models or mess around with the model and the AI. All of that we have now a supportive AI that allows us to spot that type of prompts and highlight the behavior for further investigation by the internal authorities that really have an eye on these, as well as copyrighted text and code. As Jason said, most likely some of OpenAI models were probably trained on GitHub, right? And the license is not clearly stated when it output a piece of code. So when a piece of code is output, we always run against these additional models to make sure that there is no copyright infringement unintentionally done there. And again, the models are the logs are fully auditable by the designated personnel and officers at the Farber. We have these in our secure Azure premises, and our focus was really learning through these experimentation, and only later down the road opening it up to clinical use. And we're going to use the same exact framework that we use for any drug, the clinical trial. So if you want to read more, please consult the paper we publish in NEJM AI. And we also open sourced all our code, our training material, the broad strokes of the policy. All of that can be found linked in the GitHub together with the paper. If you actually follow the link from GitHub, you'll get access to the PDF of the paper directly. And with that, this wraps our presentation, and Jason and I will be very happy to take any questions while we keep on the screen this slide, because it is really dozens of people who contributed to this, and Jason and I were really honored to work with them throughout this journey. And again, happy to take any questions.
Well, thank you to you both, Jason and Renato. Excellent presentation on a timely topic.